Hello and welcome to today's webinar, Culturally Adapting Evidence-Based Treatments. My name is BC Echohawk, and I'm a Communications Coordinator with the Native Connections TTA Center. On behalf of the Native Connections team and Contracting Officer Representatives Maureen Madison and Jan Dunbar Cooper, I'd like to thank you all for joining us today. In a few moments, we'll start our presentation. Today's webinar is being recorded and will be available in the near future. Because we are recording, all phone lines will be muted to minimize outside noise. Please don't hesitate to use the chat box for questions throughout the session. You can also use the raise hand function and we'll call on you for comment. But first, opening us up in a good way today is Grantee Technical Assistant Hunter Ginia. Hunter?
Ani, Gisa Ninin Indigenous Wabajan Shido, Mount Pleasant, Michigan, Dida, Saginaw, Swan Creek, Black River Band, Ojibwe, Minnewaca, Grand River Band, Odawa, Anishinaabe, and Dow. Kachimagweshka Bijiek, Mompi, Nagijip, Minnewaca, Squaw, not quick. At this time, I'd like to open this up in a good way, just sharing kind of a traditional honor song from this area. And just want to acknowledge all of you as Native Connection grantees and thank you for all the work that you're doing on behalf of our relatives across Indian country. Naha, chimigwech.
Thank you, Hunter. We're going to turn our presentation now over to Charlene.
You're on mute, Charlene.
Yeah.
Okay, sorry about that. I needed to unmute. Good morning or good afternoon, everybody. I'm Charlene Pula. I'm a clinical social worker by training. I'm Hopi, Tewa, and Navajo, and home for me is First Mesa, Palaca, Arizona. But I've primarily resided in New Mexico since the 5th grade. So New Mexico is home away from home. I have a lot of friends here. Jennifer Nanez is one of them. I work at the Albuquerque area Southwest Tribal Epidemiology Center here in Albuquerque, New Mexico. I'm working on a grant that addresses adverse childhood experiences, intimate partner violence, and suicide prevention. And we're looking at screening and referral. But my background really is around school mental health. So that's a little bit about me, and welcome, and I'm eager to hear what you all have to say about the presentation. I'll send it over to Jennifer.
So good morning, everybody. My name is Jennifer Nanez, and I am from the Pueblo of Acoma. And I am a GTA assistant here at Tribal Tech and a social worker by training as well. I'm really pleased to be here with you all today and to have my good friend and colleague, Dr. Charlene Pula, review this topic with us today on evidence-based practices and culturally adapting evidence-based practices within our community. This is something that has been Charlene's passion and work within our tribal communities here in New Mexico for some time, and something that she and I like to discuss a lot together when we talk about working within our tribal communities. So I am happy to welcome her to our session today, and I'm going to turn it back over to Charlene to take us away.
Thank you. I just have a technical question. Since now I have the remote control, do I have to admit people in and toggle through the slides?
No,
I
you
can
do
admit
not.
people for you.
Okay, all right, thank you. Ooh, let's see. Why isn't it forwarding? There we go. Thank you again, Hunter, for opening up the webinar in a good way. I appreciate the songs and the prayers that everybody said prior to the opening. The objectives for today's webinar is to identify the difference between evidence-based treatment and compare it to what is the evidence-based practice process. That is one item we'll be discussing today. And then learning how to culturally adapt evidence-based treatments for our programs. What does that look like? Are there frameworks that exist to do this? And the third is learning how to utilize the program match table to find what is the most appropriate intervention or evidence-based treatment for the program to adapt, and things to consider around your organizational structure. So before we start any presentation or any webinar, we want to make sure that we provide some of the background information or demographics. There are 5.2 million American Indians and Alaska Natives in the United States that make up 1.7% of the population. And there's over 567 federally recognized tribes. And about 70% of American Indians and Alaska Natives live in the urban areas. And when we're talking about health disparities, the leading causes of death for American Indians and Alaska Natives is heart disease, cancer, unintentional injuries such as motor vehicle accidents, and suicide and diabetes. And the second leading cause of death for American Indians and Alaska Natives between the ages of 10 to 34 years old is suicide. So we're losing our young people at a young age. And with these disparities, I'm sure you could all understand that this can lead to an overwhelming sense of loss and grief, which then could lead to feelings of isolation, depression, a sense of hopelessness and loneliness. And it's not to say that all these disparities are gonna fracture families, because I believe American Indians, Alaska Natives, we still have our culture, we still have our language, we still have a connection to families. So those protective factors are really important to enhance our resiliency. So culture and family is still very much part of our American Indian and Alaska Native communities. So before I start, I wanted to kind of give a historical development. What is evidence-based? How did it come about in our nation? How did it impact IHS? How has it impacted the tribal program? So the first few slides are going to do more of that historical development. Evidence-based, the term evidence-based developed from the medical field in the 90s, and it was referred to as evidence-based medicine. As before, I said I was a social worker. I am a social worker. So I'm kind of going to focus on the social work perspective here. Back in the late 70s, social work started to look at what was evidence-based, but back then we called it empirical clinical practice. We wanted to start showing how can we demonstrate that the cases that we're working on, single case studies, that there are clinical outcomes. So we started to look at new standards of clinical practice, which included looking at research methods. How can we improve our assessments? How can we develop treatment plans to outline the outcomes and evaluate what we're doing? And so it really was looking at how can we evaluate our practice and show that we have effective outcomes. So now that we know that the term evidence-based came from the medical field, the American Psychological Association started to identify their own research standards for empirically validated interventions. And this started in the 90s. They wanted to show, hey, our interventions do work, and this is how we're going to evaluate them. And this is how we're going to incorporate some of our research methods to show the clinical outcomes. And so APA started to go on this evidence-based journey, as well as social work and as well as medicine. And it was really out of the medicine field that they created this process we call the evidence-based practice process, which is a decision-making process about patient care, looking at the research findings and identifying what's going to work with this population we're seeing. And because we want them to get better, so we want them to have positive clinical outcomes. And I'll talk about that a little later. But what happened is the APA adopted it. Then other health and human services, such as nursing, clinical counseling, and criminal justice started to adopt the terminology evidence-based. And then pretty soon, in the late 90s, social work started to talk about this evidence-based practice process. But before we get to the evidence-based practice process, as I stated before, the objectives was really, or one of the objectives was to really look at what does EBT mean versus the evidence-based practice process. So for evidence-based treatment, what we're referring to is an intervention that demonstrates at least effective outcomes in at least 2 experimental studies. And it's usually in the form of a clinical treatment manual, so such as DBT, dialectical behavioral therapy, MST, multisystemic therapy, motivational interviewing, like these treatment manuals that we've all seen in Indian country. I like to think of evidence-based treatment as a product. And when I think about evidence-based practice process, it's a decision-making process. So 2 distinguishing definitions. And sometimes in literature and even as people talking in the field, we sometimes use these terms synonymously, which is evidence-based treatment, empirically supported interventions, and then empirically evidence-based interventions. They all mean the same. So I just wanted to clarify that. So now we're talking about that decision-making process. It's a 5-step decision-making process referred to as the evidence-based practice process. This is a fluid process. You kind of, as a clinician, going back and forth. And I think some of us who are practicing clinical social workers, this has been emphasized in our training and in our curriculum. And so what it really is we're looking at the literature, and we come to the literature with the research question. And so let's take, for instance, I'm looking for what interventions are out there to treat depression among American Indian adults. Just a broad question. That's what I would put out there in the literature. I do that. Intervention, treat depression, American Indian adults would be my search string. Then I look at the literature and find, oh, there's not that much information out there. There may be 3-4 articles that are for American Indian populations, but maybe the majority of them are for Latinos or are African Americans, but not specifically for American Indians. So I use what I found and I critically analyze the evidence and think, okay, what is the, something happened. Can I go back? There we go. And looking at the quality of the evidence to find out, okay, my client is coming from a rural community, lives on the reservation, doesn't have a lot of access to resources, knows he's dealing with depression, has depressive symptoms, and wants to get better. And he has a family. So, and he's in his mid-20s. So that's the client preferences. That's the information I'm collecting. So I'm looking at these treatments and I'm thinking, well, DBT, would this really work with this individual, or would cognitive behavioral therapy really work for this individual? So I'm kind of going back and forth, asking these questions, and maybe even contacting my clinical supervisor or another colleague asking, what do you think would be the best route given my situation? And so I decide then, based on the evidence, to go with providing cognitive behavioral therapy, because this individual says, you know, I really want to feel better. I don't want to be in therapy for 6 months. I want something short term. So we all know cognitive behavioral therapy is short-term interventions. So I integrate the information, I implement the intervention based on my client's preferences, values, and needs. And then I go back to evaluate, is this really working? I ask him, was this effective? Do you feel like your depressive symptoms have been reduced? Do you feel you got more motivation and energy to do the things you want to do? So you're constantly evaluating the effectiveness of the intervention you applied. So this is why this is a fluid process. It's these 5 steps that go in and out, and you're constantly evaluating as a clinician, is this working? What do I need to change? That's the evidence-based practice process. Whereas the evidence-based treatment is a product. So now that we know the definitions between evidence-based treatment and the evidence-based practice process, now we got to look at, well, why are we even having this discussion about evidence-based? Well, there were 2 reports that came out, Crossing the Quality Chasm and the President's New Freedom Commission on Mental Health report that came out in the early 2000s. And the Crossing the Quality Chasm from the Institute of Medicine, this report really impacted how healthcare systems should be providing care, quality care, to improve clinical outcomes. So this report had 6 aims, and those aims were: healthcare should be safe, healthcare needs to be effective, so we need to start measuring, are we meeting those clinical outcomes? It must be patient-centered is the 3rd one. We have to consider patient values, their preferences for treatment. Care should be timely and efficient, so we should reduce our wait times, stop reducing our times to delay care. And healthcare should be equitable, so everybody should have access to this quality care. Those are the 6 aims that came out of this report. And it really influenced the way we provide mental health care at the federal levels, at the state and local levels. And we know IHS, Indian Health Service, is a federal entity. So it obviously impacted IHS, and then it trickled down to impacting the tribal programs. And the way it impacted tribal programs and IHS is now, as providers of those systems, we had to select an evidence-based treatment. So this report really impacted the healthcare system. And then in 2003, a second report came out, which is the President's New Freedom Commission on Mental Health. And it really was about how can we improve the quality and the accountability of our mental health services to address those organizational system fragmentation and improve the delivery system to our clients, to our patients. And so this report identified the gaps and made several recommendations. And one of those recommendations was that we need to select an evidence-based intervention as standard practices of care. That was coming down from the federal system. So obviously that was going to impact IHS, it was going to impact Medicaid, it was going to impact Medicare and the VA. The other part of this report is they started to state We also need to start looking at new research evidence, developing new interventions that could treat and prevent mental illness. So we need to start looking at other research too, or developing our own research. And so now that we know that this has impacted IHS, then we have to start looking at the budget. Like, how does this impact IHS as far as them implementing services? And when we look at this, we all know that IHS is severely underfunded and under-resourced already. And if we look at when they're billing for services, more than 80% of the budget or their collections is coming from Medicaid and Medicare. So obviously they're going to be telling IHS, you need to select an evidence-based intervention to treat the behavioral health disorder or what's going on with the client. Then we look at the budget in 2017 and 2019 at IHS. Over here to my right is substance abuse. They're receiving double than what mental health is. Now, mental health is having to select an evidence-based intervention. They're having, most of the time, these evidence-based interventions ask for a licensed clinician or somebody at a master's level. So they're operating with half the budget to do this. And the reason why I'm outlining this is because I want you to understand that, you know, IHS is severely under-resourced, and then we have this other demand of selecting an evidence-based intervention with not a lot of staff to implement it. With that said, I wanted to make sure as we're talking about evidence, we talk about what's the science behind it. What is evidence-based? Who made up this definition? How do we know it's evidence-based? Well, there's this term called the hierarchy of evidence in science, whereby this top tier is the highest quality of evidence. So if we start from this lower end where the editorials and these case reports are at, this is what they consider the lower level of evidence. The quality goes up as you go up and up around here, which is considered the gold standard of evidence. And if you look to my right, the risk of bias is higher when we do these type of studies. But when we go up this hierarchy, the evidence, the risk of bias is reduced up here at the top. And so I'm going to be talking about a systematic review that Palmerville and Gahn did. And the systematic reviews and these random control trials are kind of considered the gold standard of evidence. And so a systematic review is, once again, starting out with a research question. Let's say, for instance, we'll stay with the topic of looking for interventions to address depression among American Indian adults. So we look at the literature, we're looking for what's out there. We give it a time frame. Maybe we look at the evidence for the last 50 years. We collect the evidence, and then we're looking through it and saying, okay, this one was done more with the Latino population. This was done more with the African-American population. I'm really looking for American Indian adults between the ages of 18 and let's say 35 or 40. So you're really honing in on what is out there. And then when you collect and looked at all the information, maybe there's only less than 10 studies out there. So then you evaluate that, and you can be assured that you did the best job at looking at the evidence because you've collected it across a long range, a long date range. Along with that are those randomized control trials, which is those treatments. So we're going to implement an intervention. One group with informed consent says they want to participate. One person gets the treatment, the other gets the placebo, or gets the wait list, or gets no treatment at all. And so this is kind of like what we're seeing with the vaccinations, right? The random control trials that are happening with the vaccinations. People are signing up to be a part of the random control trials, and they understand that they're going to either get the treatment or the placebo. And the scientists are comparing the results to say, hey, this really truly had an effect. So these are considered those gold standards of research. Then we go further down and we look at the surveys are done like mid-range. That's kind of like the quality of evidence is mid-range, and the risk for bias is like mid-range. And then we go into case studies and more qualitative studies down here. It's considered like the quality of evidence is lower and the risk of bias is higher. But if you don't have a lot of research on Indigenous populations, you have to start somewhere. We can't really start from the randomized control trials. We have to start with some of those qualitative studies to gather information about what's going on, whatever phenomenon it is we want to study. So I really wanted to concentrate on this because it really informs information about the next slide. So I was in my dissertation as a PhD student, I was looking at the literature, and I was wondering what evidence-based treatments are really out there for American Indians to treat mental health disorders. And what I found out is there's over 340 evidence-based interventions for mental health and substance abuse. That's for all people. That's just not Native American. That's just in general for all people. And then I looked at the systematic review. Remember that gold standard of evidence that was done by, Palmerville and Gahn. And they looked at studies for what studies were out there that use psychotherapy interventions to treat mental health disorders with Indigenous populations. And what they found is they found only 2 controlled studies that were used. But what I wanted to elaborate on is they found a total of 44 articles that treated mental health disorders with Indigenous populations. Out of those 44, 20 were quantitative, some were surveys, and 16 were qualitative, and then 8 were mixed methods. But what they found was there were no treatment interventions for Indigenous populations they found in the literature to treat bipolar disorder, schizophrenia, personality disorders, or even eating disorders with Indigenous populations. So that severe mental illness was missing to look at what was out there, what works to treat those disorders. And so what they also found out is those studies, those 44 articles that were out there, all of those interventions had to be culturally adapted. And I felt that was like really interesting to find that out. And to understand what were those 2 studies, those 2 controlled studies they found in that systematic review. One was the motivational care planning to treat depression and coordinate care with a Northern Australian population. The second one was a intervention to treat depression with adolescents. It was a cognitive behavioral therapy intervention, and it was with middle school students at a Midwestern school on the reservation. So both these 2 had to be culturally adapted to fit the population they were serving. So I'm thinking, okay, so all our interventions that we have to select from, all these have to be culturally adapted is what I was hearing. And so I started looking at the literature again, and I found this report done by the Department of Health and Human Services, where they conducted a compilation of studies, controlled clinical trials that were done to develop these EBT guidelines for bipolar, schizophrenia, depression, and attention deficit hyperactivity disorder. They were looking for select studies that developed these guidelines. And they started looking at this since 1986. And then they found like 10,000 participants participated in these controlled clinical trials. And what they found out is that nearly half of them did not report the race. So that's about 5,000 people who did not report the race. And if we look at it even further, is that only 3,600 were white who participated in these studies to develop those evidence-based treatment guidelines for, like I was saying, for bipolar, schizophrenia, depression, and ADHD. Then we look at the African-American population. There were only 561 who reported their race. Compare that to Hispanic, 99. Compare that to Asian American, Pacific Islanders, only 11. Then we look here at American Indian, Alaska Natives, none. None were reported. And so that made me wonder, okay, so now we're having to select an evidence-based treatment that really isn't for our communities or done with our communities. So why are we seeing, so how are we going to change this? How are we going to change this paradigm?
So,
And
Charlene, so just a moment. So in the chat box, we're going to put a question. And as we're talking about this, tell us what you all think are some of the barriers to American Indian participation in studies like this, and why this is impactful for our communities. So we'll put that in the chat. Feel free to respond, and then we'll take a look at those as we go through.
Okay, do you want to raise your hand or stop me in case, because I'm not looking at the chat. I want to, but I also want to present too at the same time.
Feel free, go ahead, and then I'll check the chat as you go.
Okay. So many of us know there's a significant distrust of research, because are they going to do research the way we want them to do research, which was kind of more from a CBPR approach, right? Community-based participatory research approach. We want them to come talk to us about what it is they want to do, but also they need to hear what we need. This has to be a collaborative relationship. It just can't be someone coming into the communities and saying, this is what I need from you. It has to be a collaborative approach. And so obviously distrust is really one, distrust of government in general. We're seeing this with the vaccinations, is that people of color are not getting the vaccination because there's a lack of outreach and going into the communities. So now we're seeing more people going into the communities to ensure people of color are getting the vaccination. And then the active outreach really isn't occurring. Jennifer, did you want to say something?
Sure. So just again, in the responses that are coming in, everybody is right on the money in what we are addressing here. So what we're seeing is a few responses include like past violations of informed consent for American Indian populations and research questions that aren't relevant to our communities or don't reflect our communities, trust issues and staffing changes among professionals who lead the studies. I have a one note here on helicopter effect, and maybe Tara can explain that a little bit more in her chat over here. And again, that mistrust, lack of outreach, everything that you just talked about. And we're again seeing that consistently with responses, seeing only certain types of evidence as valid. That's a good point as we're talking about adaptations today and what that gold standard is, but really where we're starting with and starting out. Gary has a great one. We have to speak in a language that is foreign to us, essentially concepts that can be foreign to us in terms of our way of thinking, and questions that are technical when we talk about surveys that are difficult to read and difficult to answer. So great responses, everybody. I appreciate it.
Yeah, thank you. You guys are right on the money. I think it's really important as if communities are going to get into a research partnership, that we really look at some of those the details of the community-based participatory research domains, or are there recommendations on how to do research with American Indians. And then there's this other, it's called TPR, Tribal Participatory Research Principles, are also out there. So there's good information out there to guide us on how we should approach a research partnership. That's for sure.
Definitely. And we had a few more just to insert these really quickly. One of the issues too can be timeliness of surveys versus making results public. That came from Verna. Very true, because we often see surveys happening within our communities, but then that information isn't relayed back to the community at the end. So that distrust also again can come into play. And another good note, elders don't understand sometimes what is being asked, and it may be hard to explain to them in terms that they understand. And so that's again very key, because our elders really do influence the way we begin to see efforts within our community be effective.
True. Having an elder's voice is really important. At the same time, being respectful and making sure they understand the question being asked, and the question being asked in their language, right? That's really important too. Let's see. Okay, here we go. Now that we're talking about what's out there. Now I was like, you're telling me there's only 2 interventions to treat mental health disorders in Indigenous populations. I felt like, I don't know if that's totally true. I've heard of other interventions that are out there. And so when I went to the literature, I found others that were considered practice-based evidence. Maybe they haven't reached that evidence-based treatment level. Maybe they've only done one study and now they're working on their second study. So one of the couple of interventions I saw out there to treat mental health disorders was the first one is by D. Bigfoot and Funderbark. It's a parent-child interaction therapy intervention used to treat trauma in children. A second one is by Pearson. It's cognitive processing therapy used with adult Native women who are diagnosed with PTSD. A third one is DBT to treat borderline personality disorders with American Indian adolescents. And then the fourth one is by Venner, motivational interviewing to treat depression in American Indian adults. So there are a few more that are coming out and may have not reached that evidence-based treatment level, but they are definitely on that trajectory. In mental health, I think we're kind of behind if we compare ourselves to substance abuse prevention. Substance abuse prevention is doing a phenomenal job of adapting evidence-based treatments to ensure cultural relevancy. And they have over 45 evidence-based interventions that exist out there. And I'm sure it's more than that by now. But here are just a few. Is the Family Listening Project developed by Lorenda Balone. They adapted an EBT for some of the Southwestern tribes. Keeping It Real, substance abuse prevention, done with, I think Marsiglius and Kulis adapted it. Of course, Teresa LaFramboise, American Indian Life Skills for suicide prevention. And then motivational interviewing in cultural ways developed by Dickerson. This was done with some tribes on the West Coast. So now that we know what exists, what's out there as far as evidence-based treatments for Indigenous populations, now we know we're probably more likely, if we're selecting a treatment based off the shelf and that was not done with an Indigenous population, that more likely we have to adapt it. And so what a cultural adaptation means, it's a systematic modification of adapting an evidence-based treatment, but that maintains the fidelity core elements of that intervention while adding the cultural relevant content. And this is really done to ensure that we engage, we have participant engagement, because nobody wants to put an intervention out there and it's not adapted to fit the culture or the community you're working with, because you're not going to get a lot of people to participate because it's not going to be culturally congruent for them. So some things to look at when you're looking at adapting an intervention is that social piece in the intervention. How does that intervention view relationships as far as family relationships and community? That's something that you may have to look at adapting, is that social content. How do they view culture, that intervention? Is it culturally congruent with the population you're working with? Does it have the worldview values from the population you're working with, the beliefs, the traditions, the values? So that's one area you might have to adapt. The third piece is the context. Where was this intervention done? Was it done in urban areas? Was it done in rural areas? Was it done on the reservation? I remember when we were working on a substance abuse prevention curriculum, and the intervention was done in an urban metro area. And one of the scenarios was the kids waiting for the bus and there's the metro line or the subway, something like that. And I was like, that doesn't apply for our kids here on the reservation. Usually it's going to be a dirt road, and it's not going to be as heavy traffic as we would see maybe in DC or LA. So those types of things that we need to look out for. Now, there's two different types of culture adaptations. One is considered a surface adaptation, where you're just changing the visible features of that intervention to fit the social and behavioral aspects of the target population you're serving. So that's maybe changing the print, incorporating some of the tribal languages into the content, changing the audio-visual pieces, but you're not modifying the core intervention of that EBT. You're keeping that. The deep structural adaptations is really involving revising those core components of the intervention to ensure that you're reaching the target group's cultural values, their worldviews, their traditions. So you're changing the core intervention components. And I know Jennifer's going to talk after this, but so now we know there's two types of cultural adaptations. Now we got to look at how are we going to approach it? Are we going to use a top-down approach or a ground-up approach? And so a top-down approach is we select that EBT from the shelf, and then we make those surface adaptations, maintaining the original intervention. That's a top-down approach. Or are we going to do a cultural ground-up or a culturally specific approach, which is we're not even going to look at the EBTs yet. We're going to ask the community, what are the risk factors that you want to address in the community? What are those cultural or protective factors that we want to keep and enhance in our community? We want to address what are the unique needs first. Get their information from the community, identify those practices, those beliefs we want to keep. And it's more of a grassroots movement because you're mobilizing the community to say, hey, tell me what it is we need to focus on and how we should address it. And that's considered a ground up approach. Now, both approaches are effective. It's just you as the program directors, as the providers, as those working in those systems, what can you do? A top-down approach does require resources, but a ground up approach requires more resources and more time. So it's really up to the program to decide, and both are equally effective. Okay.
All right. So I wanted to share a little bit about what that looks like. And many of you have actually probably already experienced this yourselves as well. But I wanted to give you a bit of a historical view from my standpoint in working within that framework, both top down and ground up. So I come from the Pueblo of Acoma, and years ago, way back in the Hamaha days, as we say, I had to oversee a brand new grant that came out through the Indian Health Service, and it was the MSPI grant, one that many of you are familiar with in our communities. And at that very first early stages of that particular grant exploration in our area, at least, there wasn't a whole lot of guidance, with the exception of we should be utilizing evidence-based practice approaches in looking at suicide prevention, outreach efforts, and prevention programming we were using within our communities. I was very new, of course, at that time to administration and also in leading efforts in prevention, but I was familiar with treatment approaches in a therapeutic setting, but again, they can be very different. So we didn't have a whole lot of time to get rolling within our grant project, and we essentially were given a list of evidence-based practice models and promising practice that were available for use that would meet the need of our grant or meet the requirements of our grant. Our first challenge was, of course, finding someone locally within our New Mexico area. And again, we live in a very rural community within the Pueblo of Acoma, and New Mexico overall is also a very rural state as it is. So our first challenge was to find individuals who would be able to provide us training within that evidence-based practice model that we selected, and also take a look at what could we potentially do to become trainers ourselves for that selected model within our community. So when we first selected a model, we actually picked ASSIST. It was one of the first ones that we picked out from the list, Applied Suicide Intervention Skills Training, because our work was, again, focusing on suicide prevention at the very early stages within our community. And we presented this as is. And what we found is, one, we had to pick facilitators who unfortunately were not American Indian, nor were familiar with working with tribal programs, but they were the most local folks to us and the ones most willing to come out to our community at that time frame to do training in the ASSIST model. And I just want to say a quick caveat here that it's absolutely no ding against ASSIST overall. It's a great model, but again, in looking at good fits and good adaptation with the community, sometimes even great models don't always work. And this was a good example of that. When we presented the model as is by the facilitators who didn't know our community, it wasn't well accepted. In fact, many of our participants for that particular session, training session in our community, were very adamantly opposed to this model by the end of the day. And were very taken aback by some of the abruptness within the model itself, the directness within the model itself, and not having time to really spend and process out like we do need to as tribal community members about issues and taboo related to suicide prevention. So we had to step back after that very first training event in utilization of this model and say, time out. Maybe the way it stands as is doesn't work for us. So we need to see if we can make some adaptations to this. And to Charlene's point, we began looking at some of those surface level adaptations that we could do with the model. The next step we took was to find someone who was willing to work with us as tribal community members who had worked in tribal communities before and who was willing to work with us on adaptations around the assist model itself. And we were fortunate to find someone that we were familiar with finally and be able to have her come out and work with us for the adaptation. We extended the time frame even to 2 days to put together the presentation and training module for assist, to give our community members time to process, to give our programs time to talk about our own data and how it impacts us, and to talk about how some of the skills that assist proposes would work within our community. Well, that second training included a lot of the same participants who sat through that very first training with assist and who, again, were adamantly against our usage of this. However, the second time around, in these surface level adaptations, it actually went way better. In fact, it was much more well received, and we had much good conversation come from that and planning that came from that particular training session within the assist model. What was interesting though is when we went to present back to our project officer at that time frame and then on to assist itself, we got our hands slapped and said that adaptation to the model was not allowed at that time point. And over the course of time, we do know that there has been changes to the assist model that have become much more culturally appropriate for our tribal communities. But at that time frame, and again, this is well over a decade ago, there was not that ability to adapt the model. And we were then again told we could not implement that training practice in the manner in which we did. We would have to stick to fidelity. We would have to stick to time frame. We could not interject our own community culture into it. It was very disheartening at that time for us. And so we had to really figure out what our next steps were. What was interesting is we also then, by this time, had become a Native Aspirations community. And Native Aspirations gave us a chance to look at the community readiness approach and that particular model as well. And it helped us to determine, like, okay, maybe assist is not in the stage of readiness that we're at. We need something that's much more within our stage of readiness. So that's one thing to consider when we do the ground up approaches, is to look at where we're at in terms of not only our community culture and values, and does this particular model fit, but also our level of readiness. Because there are models out there that are a little bit further down in our readiness versus where we might be at right now. In that time frame too, though, we were able to begin to say, okay, we also need to be asking many more questions about evidence-based practice models that are out there and investigating whether or not they really are a good fit for our community. Can they be adapted? Are they good fits for our cultural values? And are we able to integrate those into these practice models out there? And it was around that time we came upon a model called the CONNECT model out of NAMI, New Hampshire, National Alliance for Mental Illness out of New Hampshire, the New Hampshire chapter. that particular chapter had developed its own curricula and had become by this time a promising practice and was recognized by the Suicide Prevention Resource Center and was getting into what we call NREP at that time for SAMHSA for review for, again, evidence-based practices. And again, acknowledging it as such as an EBP. For us, that particular model, which is based in a socio-cultural economic look and framework, really did fit our community because we see everything as relational. Our communities, our clan relationships, our family relationships, and nothing happens in a vacuum. And that particular model really spoke to that. And so for us, it was great to have the chance to see something that may fit. And furthermore, as we met with the folks in trying to bring that practice to our community, found that they were very open to allowing us to make sure we integrated our cultural values. We had time to process as we walked through concepts. We could talk about taboo and what was the meaning behind taboo and how that related into the skills we were trying to teach as part of the model. And again, making sure we even inserted our own data into the model, which is also very important because most things that we were seeing overlooked, again, big national data, and again, didn't really speak to our communities. We needed to have our participants understand that it was an issue within our community. So that finding that best fit and that best approach, again, really helped. And yes, if we are going to build models within our communities, we are starting out kind of at that lower level, but we have the ability to build up because now over the course of time and over this course of exposure, now we understand how that process works and where that comes in for our communities and what fits us best. So I really would challenge folks again to take a look at that. And for us, moving to a model that fit, moving to a model that was adaptable, moving to a model that we really worked from the ground up to bring in as well as work within our community was a game changer. And for us, it really launched all of the work that we began doing within our community to build crisis response teams, to build prevention efforts within our communities. And one thing I shared with BC and Charlene, and I've shared before in other settings, our benchmark around this was a community walk that we did in our very first early years, very, again, small numbers of individuals, 10, 20, up to about 35 people. But by the time we found a model like this that fit, when we work within the community readiness framework to look at our level of readiness, we found that our efforts were finally having impact. And the model itself really lent itself to that because it now was something that fit within our community. So we went from very small numbers of people participating in our communities around suicide prevention efforts in our community to, I think it was our third year or so, where we had 350 people show up for a community event. And we thought, okay, we're seeing some progress. This is awesome. We've never seen numbers like this before. Maybe it's an anomaly. But as we continue work and we continue utilizing the model and utilizing it as an education tool within our communities, and as a building tool within our community, we found that it grew. In our benchmark, again, walk proved that for us because publicly then we saw those numbers increase. The following year after that, we went to 650 people. And the year after that, we hovered around 500 to 600 individuals. Not bad for a community with only 2,800 people on reservation at the time. And so again, there's some amazing things that we can do when we have evidence-based practice models that work, but work within our framework as a traditional Indian people. So I'm going to turn this back over to Charlene.
Thanks, Jennifer, for that information and for the examples. As you can see, both approaches what ground up approach can be effective, but it does take time to build that, which, you know, is really important too. It's good to have options as we are working towards ensuring that our cultural components are included in interventions that we provide to our people. When do we adapt? So this is something that all programs have to consider, is when, if you're going to do select an EBT that was not built for your community versus doing a ground up approach, when do we adapt it? Well, you adapt it when you're providing the intervention and say there's a lot of people who show up the first session. Let's say 30 people show up. Second session, it's 15. By the third session, there's only like 5 left for the remaining intervention. So there's a lack of clinical engagement. So it's really important to look at, okay, I need to consider adapting some components of this intervention because we're losing participants along the way. Another one is when you have unique risk factors. We talked about the rates of suicide among our young people, and then looking at some of the rates regarding an overwhelming sense of grief and loss. Those are some unique factors. And then what are our protective factors? Our culture, our language, our family systems. Those unique clinical symptoms, which is that overwhelming sense of loss and grief. These are unique to American Indian populations. That's when you consider, hey, we might look at adapting this intervention. And then if you're doing a pre and a post test, if you're implementing the intervention and at pre-test, you see that the result, that the behavior changes didn't really have an impact at the end of your post test, then you're thinking, okay, let's look at adapting some of the components of the intervention. So this is where we look at, okay, now we know what cultural adaptations are: surface, there's deep structural adaptations, there's the top-down approach, the bottom-up approach. Now, what are some of those cultural adaptation frameworks or models that exist out there that we could utilize? And so there's 3 that I selected, but there's an article by Burlew, B-U-R-L-E-W, from 2013. He identified 13 cultural adaptation frameworks. So really in 2000, mid 2000, like 2005, 2006, we started to understand there aren't a lot of evidence-based treatments for Indigenous populations. So if we're going to have to culturally adapt, what approach do we use? And I really appreciate this article by Burlew because he lists the 13 models. But one model that stands out is the Strengthening Families Program Adaptation model that was developed by Comfort. And this model has been used with African American populations, Latino, Asian American, Pacific Islanders, and American Indian populations. So very diverse and has been used in 17 different countries. And I know you can't see this very well, but Comfort, she has 9 steps, and one of them got cut off, but it's 9 steps to consider if you're going to culturally adapt an intervention. And this has been done with American Indian populations. A second framework to consider is one by Whitbeck. He developed this culturally specific prevention model back in 2006, and this was done specifically with American Indian populations. And his model states that we should meet with our community first, identify those risk factors. Those community members must be the elders, leadership, providers, community advisory board members, and you're going to ask them, what are those risk factors that you see? What are the protective factors we want to keep and enhance? Then you go back out to the larger community and do a survey of what problems do they see exist and what do we need to keep. Then you come back with that community, that group, and you talk with the cultural experts and say, hey, how can we translate this in our cultural context from our worldview? Then you develop the intervention and the measures for that curriculum, and then you pilot that curricula or that intervention. And that was developed by Whitbeck specifically for American Indian populations. So the Strengthening Families Program adaptation model is more of a top-down approach. And this culturally specific one is a bottom-up approach or ground-up approach. Then this third framework developed by Barrera and Castro, which is called the heuristic framework, was not done with American Indians and Alaska Natives, but was done with Latinos around a diabetes prevention intervention. And I selected this one just because We all know that programs are under-resourced sometimes, and they don't have the ability to do all these adaptations and evaluate. And his model includes 4 steps. Once again, identify those risk and protective factors. You've already selected an EBT, make those preliminary adaptations based on the feedback from the group, test it, and then adapt and refine it. This is Barrera and Castro. And what all these 3 models have in common is, 1, ask the community, what are those risk and protective factors? The community is going to know. They're going to tell you. They're going to tell you what to address and what to keep. And then review the literature about those interventions that you're selecting to ensure what components are culturally congruent for you and what do you want to change. And then 3rd is always ask the cultural experts. All of those 3 models say you must have your cultural experts on your team when you're looking at those adaptations. And this last point I did find in my dissertation study is, when we're looking at adapting interventions, it's 4 times more effective with a homogeneous population. So 1 tribal group compared to providing an intervention to a heterogeneous group, such as some of the urban centers who have to provide interventions to over 100 or 150 tribes, not just 1 tribal population. So the literature does say it's 4 times more effective to adapt an intervention for a homogeneous group compared to a heterogeneous group. Just something to think about. As we're looking at, now we know what frameworks exist out there to culturally adapt interventions. Now we have to look at our organizational structure. What do we need in order to move this process forward and adapt? We have to look at our organizational culture and our organizational climate. Do we have the resources to do it? We're already under-resourced. Can we add something else on another person's plate? Do we even have the buy-in to move forward? Really ask your staff their opinion and their perception about how to respond to these adaptations, because you want that buy-in from the beginning so that you can work as a team and move forward as you pilot and then as you adapt. So that's one thing to consider. On that same level is looking at this handout that's called the Sources of Program Mismatch. This is really for administrators, program directors, service providers, and paraprofessionals to look at. These are things to consider before you start adapting an intervention. So one thing you want to look at is the intervention. What language was it done in? Was it done in English? Was it done in the tribal language? What ethnicity group was this intervention used with? Was it people of color? Were they ethnic minority? Were they more white middle class? You want to look at those type of things, because if you want to select an EBT, you might want to choose something that's done with rural communities, maybe in a reservation or maybe in a rural area with Latinos that, okay, maybe we can adapt certain things, but at least we know the context is in a rural area. Other factors to consider is, what are they addressing in the intervention? What's the risk factor? Are they addressing suicide? Are they addressing depression? You really want to make sure you're selecting the intervention to address the risk factor you want to address. Then what type of staff is needed to provide this intervention? Can we do this with paraprofessionals? Do we have to do this with mid-level practitioners? What is the level of competency that we need? And then looking at the cultural competency, do our staff need to be trained in culturally competency or culturally sensitive practices? So looking at those pieces when you're looking at the interventions. Another aspect for administrators is looking at community readiness. Is our community ready to look at adapting an intervention and piloting it? Where are we at on that readiness scale? And what other experts do we need outside of our community to evaluate those interventions to see if they're effective? So these are a lot of things for programs to consider, and this table provides like a comprehensive view for the programs to look at as they consider the journey of culturally adapting interventions. That's it for the presentation. If you guys have any questions, we'll open it up for questions, and thank you for your time.
Thank you, Charlene, and I appreciate it. We do have some requests in the chat box for some resource information. So if you would like some resources sent to you, again, on those components that Charlene has spoken about today, do put your email in the chat for us and we'll copy that and we'll see what we can send on to you in full. So you have that information. We do really want to, again, thank you all for being with us today. This idea of adapting adapting evidence-based practices into our cultural communities is incredibly important because we do not see this trend going away. You know, this is something that we are being asked to do on many levels from both governmental standpoints and otherwise. Funding streams like grants, of course, that you can see are asking us to, again, look at evidence-based practice usage within our communities. And really for good measure, in part because they want to ensure that we're using something that is effective. However, we do have to adapt it to work within our communities, for it to work within our population. Again, one of the areas that we always talk about between Charlene and I and many others is we have a real need to begin to develop our own. And so like Dr. Teresa Laframboise and the American Indian Life Skills that generated within the Pueblo of Zuni and then became an evidence-based practice model for use nationally, we actually do have that ability to do that. It takes some time though, and we have to be willing to go through those hoops and walk through all those layers of the hierarchy for it to be studied and to be considered effective on a larger scale and larger basis. But that's something for us to consider as a population. So again, thank you everybody. If there's any questions, please feel free to chime in. We've got lots of emails popping into the chat, so we appreciate it. And we will make sure that we get all of this information to you as best as possible. BC?
Great. Thank you, Jennifer. Thank you, Charlene, for joining us today. Very good conversation showing us how we can adapt those processes to better help our communities. So coming up soon are our next webinars on March 30th, Practicing Traditional Ways During a Pandemic. On April 13th, Suicide and Prevention using Culture. That title has changed just a little bit, but we will be talking about preventing suicide using cultural practices. May, supporting LGBTQ2 spirit youth in our communities, and followed by a couple of youth leadership webinars, part 1 and part 2. So we look forward to you guys joining us. Thank you for joining us today. And if there are no questions, we'll go ahead and say goodbye till the next time. Thanks again.
Great job, Charlene.
Thank you. Thank you for this opportunity. Bye, everybody.